Good morning.
Hello, Kumar.
Thank you for your help.
You are welcome. Let me see if we have enough quorum. Look like we are having enough quorum. Good morning, everyone. Welcome back to the September DUR with Utah Medicaid. Just a few reminders for our meeting today as usual. If you are dialing in via telephone, Google Hangout has muted you. If you need to speak to the group, please press *6 on your phone to mute and to unmute. If you are using your laptop for audio and visual during the meeting, you can control the mute function on the Hangout. We kindly ask that only those who are speaking to the group unmute the device. If you are a board member, please preserve your question until the end of the presentation or may ask in the Google Hangout meeting chat. For public comment, if you would like to provide a public comment, a COI must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendees that are not member of the DUR board, please enter your contact information in the Google Meet chat or email medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meeting to help us improve our process moving forward. Thank you. Before we started, there is some slight change to our agenda today. We have a really packed schedule this morning, and I would like to share the agenda before we start. So after the housekeeping and the PNT update, we will start reviewing our prioritization, started with the anti-asthmatic, and then go on with the Aduhelm PA, and then Humulin PA. After that, we will go over the DUR annual report presented by the pharmacy team, and then the Drug Regimen Review Center. With that, Dr. Smith, I will leave it up to you.
Great, thank you. Yes, indeed, a very busy agenda. So I guess the first item is the review and approval of minutes.
I would like to propose a change on page 3 under number 6, letter C, line 4. The fifth word instead of is should be if there are studies to support cardio outcomes.
Okay. So an is to an are. Any other changes? Okay. All in favor of approving the minutes as amended, say aye.
It looked like Kumar maybe had it changed.
Oh, sorry.
No. I'm just accepting the ladies.
Oh, okay.
Okay. All right. So raise your hand or say aye if you're in favor of the minutes as amended.
Aye.
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 Perfect. All right, minutes are approved. Wonderful. Okay, thank you so much for that. And next we have the PNT committee update from Brian Larson.
Good morning. So this month, next week, we will be reviewing wakefulness promoting agents. So that's things like armodafinil, modafinil, WakeX, and OC. And we'll also have our annual training from the AHE, Assistant Attorney General, and we'll also be nominating and electing the chair, which we do annually. That's what we have.
Wonderful, thank you. Any comments, questions from the committee? All right, moving on then, we have our first review, which is anti-asthmatic prior authorization from the pharmacy team.
Thank you. Camila. Is the screen looking okay from? Okay. So this is the anti-asthmatic monoclonal antibody. This is our annual update compared to the form that we are currently have on our website. In this form, we are combining multiple monoclonal antibody with multiple indication into a grid and parting system. So the provider can choose the medication including Syncore, Dupixent, Fasenra, Nucala, and Xolair. In these, the Syncore, Fasenra, and Xolair are referred products. The Dupixents and Nucalas are the non-referred product as stated. Any of these indication over here, the provider can indicate it and complete the need part belong to that indication. For part one, all of these indication need to be filling out for part one that the prescriber has consulted with the allergic, pulmonologist, or immunologist, indicated what is the diagnosis of the requested, describe any other treatment the patient is currently take. For part two, it needs to be filled out for indication of severe asthma, eosinophilic phenotype, hypereosinophilic syndrome, eosinophilic granulomatosis, polychonitis, and moderate to severe persistent asthma. Those indications requiring a minimum of 3-month trial and failure or contraindication to high-dose inhaled corticosteroid, long-acting beta agonist, or trial failure of the add-on tiotropium or leukotriene receptor antagonist therapy, requiring to have the baseline eosinophil value. For part three, it needs to be filled out with part one and part three for eosinophilic granulomatosis with polychonitis. That is requiring to have trial failure with the past year or contraindication to oral corticosteroid therapy. Part four need to be filled out for moderate to severe persistent asthma indication, requiring to have a positive skin test or in vitro reactivity to a perennial aero allergen. For dosings, it requiring patient to be included the baseline IgE level and also the baseline weight. Part 5 need to be filled out for chronic idiopathic urticaria, requiring to have minimum of 2 months trial failure of at least the H2 antagonist or the leukotriene receptor antagonist. Part 6 is for the nasal polyps in adult as an add-on therapy, requiring to have 2-month trial and failure of at least 1 nasal corticosteroid. Part 7 is for rhinosinusitis with nasal polyposis, requiring to have both nasal corticosteroid and oral corticosteroid within the past year. Any non-referred product need to have a trial and failure of a referred product. We also having a pathway for a provider who want to prescribe not included indication by having an off-label or compendia criteria that must be filled out and submit for literature and evidence. Initial authorization is giving up to 6 months, with re-auth is giving up to 1 year.
Kumar?
Can I ask a small question, curiosity question?
Sure.
Is there any major change that was made to this form, or they're just minor corrections?
So the major change that after this form, Kumar, is we add the Dupixents. In our current PA on the website right now, we don't have Dupixent. Okay. And also we are just established the grid and park system.
Okay. Thank you.
You're welcome.
I have a recommended change, which is under the list of consultation with specialists.
Yes.
It seems like dermatologist should be in there, no?
Possibly also ENT when you're dealing with nasal polyposis.
Mm-hmm.
Let me. That is a good recommendation.
Um,
That would be an otolaryngologist.
Mhm.
You want to be consistent on the form.
For the sake of time, let's take notes and we can update the form with your recommendations. We have a huge amount of content to go through today. So Noon, let's not track change real time, please.
Okay.
Let's take notes and we can update the form. Thank you for the feedback, committee.
Yep.
Is there any other recommendations, comments regarding the form?
Motion to approve. It's Dr. Weinstein.
Thank you, Dr. Weinstein. Is there a second?
I'll second. This is Michelle Hoffman.
Wonderful. Thank you. Okay. All those in favor of approving the form as or with the recommended changes, say aye or raise your hand.
Aye.
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 Right.
Okay, perfect. Moving on to the next. Go ahead.
My apologize. We do have a public comment
Oh, that's right.
from
Sorry.
Brandon Yee,
Yep.
Sanofi.
Okay. Sorry, I forgot about that.
Hello, can everyone hear me?
We can. Thank you.
All right. Hello. Thanks to the committee for my opportunity here to speak. My name is Brandon Yip. I'm an MSL with Sanofi Genzyme. Respectful of your time, I think that I just wanted to add a couple of things you guys just discussed about dupilumab. Just wanted to bring some additional information. We are anticipating a 6-11 launch for asthma in about a month's time, October 21st. Some of that data publicly available. We do have some proactive resources that I can use to discuss any information that you guys are interested in. I know that we are also expecting the publication of a manuscript for this particular study in the New England Journal of Medicine. I don't yet have a date, but if you guys are interested, I could definitely bring that back to the committee. And then lastly, we do have some emerging indications coming in 2022, specifically as ages 6 months to 6 years for atopic dermatitis, looking at the first half of 2022, and then eosinophilic esophagitis in the second half of 2022. So just wanted to bring that additional information to the committee, and I'll let you guys get back to your agenda.
Great. Thank you.
Thank you.
I just noticed a typo on the form. Sorry, going back to that really quickly. It's under reference to treatment for chronic idiopathic urticaria. It said H2 blockers, I believe. That should be H1.
Okay, I can definitely take note. Thank you, Dr. Smith.
Yep, you're welcome. Okay.
I don't think, based on the public comment, that would necessarily change anything with our form at this time, but certainly something for us to keep in mind in terms of reevaluating the form in the future.
Yep, great. Thank you.
Good idea.
All right, are we ready for the next prior authorization here? Aduhelm, if I said that right? Aducanumab?
I'm not exactly sure of the correct. We've been saying Aduhelm, but let me just give some background on this form. So Aduhelm was a clinical prior authorization form that was created in conjunction with the managed care plans. So the fee-for-service form and the managed care forms will mirror one another. And so the original basis of this form was developed with guidance from clinical package, the clinical package literature information, as well as the clinical studies, as well as attending some recommendations from other states as well. If we go through the form today, we know Aduhelm is for mild dementia and mild Alzheimer's. The criteria for approval is first that the medication is prescribed by a neurologist or a geriatrician. The member is between the ages of 50 to 85 years old. The member has a diagnosis of Alzheimer's disease with mild dementia or mild cognitive impairment, as evidenced by the 3 clinical rating scales that were used in the clinical trials. The request also has to include documentation of a brain MRI within the past year, indicating lack of evidence of the following items. And again, this is consistent with clinical studies that looked at this product. The request includes documentation showing presence of amyloid abnormalities as determined by PET scans or lumbar puncture. To demonstrate, again, confirmation of diagnosis. The member has documented a 3-month trial and failure of a cholinesterase inhibitor or memantine. And the purpose of this is less expensive options. And again, Medicaid criteria can base things off of a less expensive option, trial and failure of less expensive options. The member has not experienced any of the following, and again, we have criteria for exclusion. The requested dose follows the FDA prescribing information around the careful titration regimen that is detailed in the package literature. And so this would be for the initial authorization criteria. The initial authorization needs to be up to 6 months in order to accommodate for the titration schedule, and also the MRI scans that are needed to confirm the lack of ARIA-E. The reauth criteria after 6 months of initial auth, which can be up to 6 months, would be a requirement of MRI, brain MRI, to determine absence of ARIA-E or ARIA-H before the 4th, 7th, and 12th infusion. Again, the most commonly occurring adverse event, which is significant, and we need to have evidence of that. Also, continued evidence, so these cognitive scales that were, again, assessed at baseline. So we need to have continued evidence of lack of progression of disease with the repeat of these scales, and also evidence that the patient has been able to achieve the maximum maintenance dose, which is the dose where patients did seem to respond to therapy. We'll take the reauthorization period that would be given would be 6 months. After the initial authorization of up to 6 months, the reauth period would be 6 months. Okay, we'll take questions. Oh, I'm sorry, there's public comment. Should do public comment first.
Sounds good. So our public comment, Rosalind Finch.
Yep, I'm on. Can you hear me?
We can, thanks.
Great, thank you. Good afternoon, or good morning, actually. My name is Linda Finch. I'm a medical value liaison with Biogen, and here today to talk to you about Aduhelm, which you did pronounce correctly, or aducanumab. It is indicated for the treatment of Alzheimer's disease, and treatment should be initiated in patients with MCI or mild dementia stage of disease. That's the population in which the treatment was studied in clinical trials, and there is no safety or efficacy data for treatment at earlier or later disease stages. And this indication is approved under accelerated approval based on reduction in amyloid beta plaques observed in the treated patients. And continued approval for this indication may be contingent upon verification of clinical benefit in confirmatory trials. The titration is required for treatment initiation with a goal dose of 10 mg per kilogram administered as an IV infusion every 4 weeks. As mentioned by Jennifer, it does take 6 months to titrate up to the full dose. We did not start to see the removal of the amyloid plaque until that point, and so the contingency for the clinical benefit to be seen at that time point may be a little bit premature there. And then the other thing that I wanted to comment on is the requirement for trial and failure of the cholinesterase inhibitor or memantine. Those products are not FDA indicated for MCI or an early or mild AD. And so that may present a problem to have a trial and failure of those products in this patient population. So I just wanted to call that out for the committee. I'm going to yield the rest of my time and let you spend some time discussing this. And I'm here to address any clinical questions that you might have. Thank you.
Thank you very much. Any comments or questions from the committee?
I would like to point out that the potential requirement for using memantine would be off-label because it is not indicated in mild Alzheimer's dementia. It is only indicated for moderate to severe dementia. And you may want to consider adding something that would be a contraindication would be diseases that would create CNS iron accumulation, such as Friedreich's ataxia. Sometimes it's seen in Parkinson's, which can be comorbid with Alzheimer's. And I would like to ask the pharmaceutical representative about in the studies, the ApoE4 status and whether that should be considered when using this medication.
So yeah, that's an excellent question. So the ApoE epsilon 4 is a risk factor for Alzheimer's. 2/3 of the patients in our clinical trials did have were carriers of the ApoE epsilon 4 allele. Those patients do have a higher risk of ARIA, which is why we studied them specifically in our earlier trials. We titrated the dose up, and we found that helped to reduce the incidence of ARIA. We then added that titration arm for all patients to reduce the incidence of ARIA. But those patients are able to safely titrate up to the full dose, the 10 milligrams per kilogram, and maintain that dose. So that shouldn't be a contraindication to treatment. It is obviously a risk factor for Alzheimer's, and you are going to find that in the population. And you know, physicians and patients need to be aware that it is an increased risk for ARIA.
Then my question to the board would be, should we, consider including just for the clinicians and the patients, informed consent process that they know their ApoE4 status?
I think that's reasonable. Any other comments?
I guess the one comment, and I had discussed this with Steve Pearson at ICER, because in their report, they didn't recommend any step. How difficult is that for us to recommend a step in a situation where it's not FDA approved in a mild situation? Although we know that in terms of the way practice is done, those two drugs are used every day in the mild patients. So, and I'm looking at this more from a burden on the state in terms of you have a criteria that you may not be able to enforce. So that's one thought. I guess CMS does not approve amyloid PET for coverage in Alzheimer's for Medicare. Is that an issue for the state? I also I understand the reason for the testing in this authorization request. I also hate to see the state spending the money to do testing for a drug with a significant lack of any evidence to suggest it might work. So I don't know the answer to that question, but I guess, Jen, are there restrictions on the coverage of those things? Do they also require prior authorization?
Yeah, we did evaluate coverage of amyloid PET scans to ensure that there was access. And those codes are open. And to my knowledge, they do not have a prior authorization. If there is a difference in that, we looked at it last week, I believe, and confirmed that those codes did not have PA on them. But they are available. So, although I believe, Eric, someone did mention that there aren't many machines that can perform the amyloid PET scan in the state. So that might be more of an access issue to actually getting the screening, is what I was told, that is what I heard in our dialogue with the managed care plans, is that there may not be, maybe here in the urban area is where it would have to be performed.
Okay. No, I mean, expensive drug, minimal to absolutely no data to support its use. And, it's in a field where we don't have the access to providers and facilities and technology that we need. And so I don't know how you can not implement this prior authorization as it's written, but I do think there will be some unintended consequences as a result. Although I don't know that should be completely viewed as being an issue of the states. I'm supportive of it.
This is Sharon. Sorry,
Go
this is
ahead.
Sharon Weinstein. I just had a question of the restriction in terms of the practice arena. So we have neurology and geriatrics. So probably most of the patients with a minimum, early stage dementia or minimal cognitive impairment are seen in primary care, right? So this is going to require those patients to be referred, and is that intentional, or am I missing something in terms of how this is intended to be restricted? Primary care would need to refer these patients, and we are implying a board, a subspecialty board certified geriatric medicine specialist in this, right?
Yeah, and Sharon, this is Eric. I mean, we implemented the very same criteria within our organization and have had long conversations about this. We just felt like, given all of the requirements that need to be placed around this drug, that primary care would not have the training or understanding how to use or address or interpret most of the tests and some of the different issues associated with the drug.
I would agree with Eric that in order to do the screening as well as interpretation of both MRI and the PET or CSF presence of the tau proteins, you really do need specialty training. And, most primary care physicians would not, be able to do this without, significant assistance from neuroradiologists, or you could at least, in, close consultation with a neurologist.
Right. And do you all think that includes that most geriatricians are qualified, or are we talking really about neurology and neuroradiology in terms of making this neurologic diagnosis? As geriatrics is really a subspecialty of internal medicine, right?
Actually, geriatrics also is a subspecialty, at least of psychiatry, and may also be a board specialty under neurology. But I know it is under internal medicine. It tends, and I don't know if it needs to be necessarily prescribed by a neurologist or geriatrician. That may be something we want to think about, whether you need a consultation with neurologist or, board certified geriatric specialist, if you wanted to use that, as opposed to geriatrician. Geriatrician is kind of I could call myself a geriatrician if I confine my practice to people that are over a certain age, but that doesn't necessarily imply that I would have the knowledge to prescribe this medication if I were a family practice doctor or a other primary care physician or primary care provider.
I think that was my point there, was is how we're intending to kind of I don't want to use the word funnel, but direct this. Is this to consultation, and who do we mean by geriatricians? And so I think Dr. Siegfried's point is very important here. Do we say we only want certain clinicians to make the prescription, or are we thinking that a primary care could do the prescribing if the patient was consulted and had these more complex diagnostic evaluations done in consultation with the appropriate specialist, which could include a neurologist or a boarded geriatrician? I'm not sure. And Eric, it sounds like you've had this more in-depth discussion in a system. So, you might have more thoughts about how that could be worded. I certainly agree that most primary care clinicians would not have the expertise to do the interpretations, and probably don't have the system support, even if they wanted to, to take the time out and pursue this kind of, complex, high specialty care within a routine primary care practice. So that's what I wanted to say. And thanks. I'll leave it to the rest of the group to work out the specifics. Appreciate it.
So can we maybe tackle this one at a time? First about the word geriatrician, and then about whether we want to say in consultation with or prescribed by. So maybe first the word geriatrician. Do we want to change that to geriatric specialist, board certified geriatric specialist?
I would say the board certification could apply to both categories.
Okay, so we could say board certified neurologist or geriatric specialist.
Yeah.
Yes.
Okay, sounds good. And then regarding the prescribed by versus in consultation with. I mean, people see like primary care and specialists all the time, and primary care might be their medical home where they're getting kind of follow-up and things like that, but they still may have prescriptions written by specialists. So to me, I don't see the specialist prescribing it as a barrier per se, but that's just me. Any other comments?
I would say, although looking at some of our other prior auths, like the one that we just did for asthma, it was prescribed by or in consultation with.
So an or.
So we also have precedent of a lot of things given our frontier state nature and access where we've done by or in consultation with. So I personally don't have strong leanings in either direction, just throwing that out there that we've kind of, in a lot of other realms, left it open. That being said, this is a medication that has a lot of risk and follow-up criteria. And so I think you could argue that this is one that might be worth restricting.
Yeah, the one thing I can say is we have restricted this to say the prescriptions have to come from those two professionals. I think I sort of used some very good wording when they talked about provider restrictions. They say because of the narrow benefit/harm balance and the potential for severe side effects, initiation of aducanumab is best managed by specialists. And then they add, or in consultation with specialists who have the accuracy and expertise to accurately diagnose and manage dementia. Here's what I worry. What is in consultation? I ran into my buddy that's a neurologist down in the gym, and he said, oh yeah, he thought this would be good. Or was there an actual evaluation consultation done that included evaluation of the records and everything else? So if it's in consultation with, then my personal opinion is you need to establish some parameter around what does a consultation look like and what should it include.
So
Kumar?
I think with what we could do is we could say consultation must include, and then put down 2 or 3 items, risk analysis or, side effect, or something of that sort. So it has to be restrictive. And the other problem I'm having is which particular functions have to be performed prior authorization or writing a prescription. Those are the 2 or 3 things if we can come up with that, I think language has to be added.
This is Sharon Weinstein. As I'm listening, I'm thinking we might choose to restrict this, at least initially, to these categories of specialists, because I think it's more than likely that our primary care colleagues are not likely to be jumping into to prescribe this drug, number one. Number two, I'm not sure that we could chase down all of the documentation that we would set out, what it means for a consultation. And, I was thinking, oh, it's a quick text, and my pet peeve about, text communications in our world right now is that things don't get captured in the medical record, that gym consultation that Eric just mentioned. These things don't get captured. So I think as I'm listening to this as an option, I'd be inclined to initially restrict it. If we got input and feedback from the field that there was a a groundswell from primary care, you know, that they would like to use this drug in the large population of people that we have who have early stage disease, and this restriction is impeding them, then I think we could revisit the prior auth. But I'd like to start out with this as we have it just amended, and I think not try to lay out what we mean by consultations. If people want to think along those lines, that's what I would recommend.
I agree with that as well. This is Michelle.
Mm-hmm.
I also agree. That was the conclusion I was coming to listening to this, was that starting off with the more restrictive prescribing, given that narrow window of risk benefit or therapeutic index with this medication and the expertise required, and then can always reevaluate.
Okay, it sounds like there's a consensus on leaving it as it is written. In that case,
the amendment of the clarification of board certified.
Correct. Yep, with that added. Absolutely. Sounds good. Any further comment on that one? How about any further comment on the prior auth in general?
I would comment that we move to approve it as written.
Okay, or as amended.
As amended, did we amend it?
Yeah, we amended the board certified before neurologist or geriatric specialist.
Absolutely agree.
Is there a second on the motion?
Second.
Second from Dr. Weinstein and Kumar. And all right, all in favor of this prior auth as amended, say aye or raise your hand.
Aye.
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 All right. Excellent. Thank you for your thoughtful comments there. Next is Humulin U500 prior authorization from the pharmacy team.
Hello, everyone. This is Luis, and sharing this. Can everybody see the Humulin U?
Yes.
Are you fine? Okay. I'm going to make it a little bigger. So yeah, hopefully this won't take as long as the previous review. This is for Humulin RU500 concentrated insulin. So we have the criteria for approval here. So as member has diabetes and is being treated with a total daily insulin dose of 200 units or higher, as that is the indication. And Humulin RU500 will not be used in combination with other insulins. The member and caregiver have been educated on safety administering this medication. In terms of the reauthorization criteria, updated letter with medical justification or updated chart notes demonstrating positive clinical response. And it'll be authorized up to 6 months, reauthorization up to 1 year. With the note here that patients using the Humulin RU500 vial must be prescribed the U500 insulin syringe to avoid medication errors. So very straightforward. PA review, and that is it.
Any comments? And then we have a public comment as well. Should we do that one next?
Yes, please.
Michael Shepard.
Yes, good morning.
Thank you.
I'm Michael Shepard. I'm the Evidence and Outcomes Liaison. As part of Lilly Medical, I support population-based decision makers and payers in answering medical questions. Today, there hasn't been any clinical trials for several years, so I won't speed read any data for you or summary, but rather just wanted to be here to answer any questions for the DUR board. Looking at what you wrote, the only thing that I would note for consideration is there is a U500 quick pen, and that isn't mentioned in there. So it's the only thing that caught my eye, and I'll yield all my time back.
Great, thank you.
So for the pharmacists, does that, do we need to reference different dosage formulations in this or no?
Yeah, so in this case, the title of the prior auth here is just RU500 concentrated insulin. Hopefully providers prescribing this will know that there is a pen and there is a vial. Available.
Thank you, sir.
You're welcome.
In the title, could you consider the, just adding the word products after the Humulin RU500 products? That way individuals, would know that there's, more than one option.
Yeah, that sounds reasonable.
I support that. Thank you.
Any other comments? All right, is there a motion to
Motion to approve.
Thank you, Dr. Gargaro. Any, is there a second?
I second.
Okay, thank you, Dr. Siegfried. And all right, so go ahead.
Sorry, for the record, we also need to have an opposed and in favor, just because we need to capture those as well, please.
Oh, sure, sorry. Yep. All right, so all in favor of approving this prior auth as amended, say aye.
Aye.
Aye. Aye.
Aye. Any opposed? Any abstentions? Okay, sounds good. All right. So next item on the agenda is the DUR annual report. Do we have enough time to continue with that?
Yes, we are planning to have about 10 to 15 minutes each from the pharmacy team and the DRSE.
Perfect. Okay.
So this is Joe Busby with the pharmacy team. I hope you guys can hear me.
Yep.
So had I known I was going to be presenting, I would have had my hair did. Just quickly, what we want to do is share the DUR report that we provided to CMS. All of this information you're going to see, you have seen before. It's all been approved by you. There's nothing new here, but we did want to at least give you a quick update of what we provided. As you guys know, DUR submission is a federal mandate for all, both fee-for-service and managed Medicaid programs. The reporting year is October 1 through September 30. So as you see the data that I show a little bit later, think of that period. At that time, and there still is, of course, a heavy emphasis on Support Act requirements, and there is very detailed reporting requirements for our managed Medicaid colleagues. The data that I'm going to show you is almost exclusively fee-for-service patients. So some of the utilization patterns, for example, you may see, wow, that's kind of different. Well, it's because of that. Just a quick review here. This is the year before, and this is this current reporting period. So you can see, for example, we have a few more Medicaid members here, or fee-for-service Medicaid members. It's went from, up a little bit here, increased 10%. Our total claims increased 4%.
Joe?
So,
Sorry to interrupt
sorry?
you, but we can't see your screen.
Oh, I can see it, Catherine.
Can you? Huh.
Can
Yeah, I
others
can
see it?
too.
Okay.
Yes, I can.
I've got it.
Huh. Hey, Karen, or Catherine, I intentionally blocked you, so I'm glad it's working. Shall I continue or wait for Catherine to come
Yes.
back?
Go ahead.
Just
I have it
continue.
now.
Rather than grind through all of these, usually what's of note is our percentage approved. So the year before, we approved roughly 27%. You can see that our approval actually went up to 39%, but so did our denied number. And how is that possible? Well, our number that were incomplete went from 5,212 to 0, which to me is a wonderful testament to our pharmacy team in that they reach out to our providers that are submitting prior authorizations, help them make sure that the form doesn't remain incomplete. They gather the additional information that's needed and then help resolve that. So that's, at least to me, that's what of note here. We have a number of other categories of PA resolution, but those are the smaller ones. So again, we're approving more, we're denying more, but the big change is that the number incomplete is significantly decreased. All right. Here are the top drugs by PA requests by drug. So buprenorphine, which at this time required a PA, but does not require a PA now. So that's important for the committee to know. And on down. Here's the classes. We get a lot of opioids, of course, on down. And then this is the top 5 denial reasons. So, if you're interested, you can look through these, and obviously we welcome questions on it. Here's the amount by amount paid. Now this is what we reimburse providers. This is not Medicaid's net cost. Critical difference here. So we do a lot of mental health drugs. Medicaid, of course, is the biggest provider of mental health, or reimburser for mental health in the nation. So we do a lot of mental health, and that's why you see a lot of mental health there. This is by claim count. We get a lot of gabapentin, et cetera, et cetera. Okay. And one additional reason here is these meds are carved out from the managed Medicaid plans back to fee-for-service. So that's why another reason there's an inordinately large amount of mental health in our claim count. Just quickly, if you break it out by age groups here, what we see here is, so this happens to be opioid recipients by age group for fee-for-service. We have roughly 2.3% of our fee-for-service young people receiving an opioid, and you can see the specific opioids listed here. So we've got it broken out. All of this, by the way, is mandated by CMS, how these age groups are stratified, et cetera. Just in the interest of time, let me go on to that. This again is opioid, and we break it out, or we're asked to break it out by individuals with disabilities and monitor what percent of them, those individuals, are receiving opioids. Okay. So there's kind of the statistics on it. As you guys know well, we've done a bunch of interventions at this time, both in our system. So we do things like, we call them hard edits. That is, if a prescription is submitted for 5,000 morphine milligram equivalents or NMEs, it doesn't process. So it's called a hard edit. So we've done a bunch of those, as you guys know. We've reduced our MME limit here. We limited the number of opioids for pregnant members. We removed our PA for Suboxone. We also, which we've reported on a number of times, launched both a peer-to-peer program to pharmacies, and then with our high-dose program providers that went from 64 patients receiving 90 or more. And that's opioid patients that are not receiving cancer, or don't have a diagnosis of cancer pain. We're down to 32 members here, okay? At the same time when Medicaid enrollment increased. So that's just a quick review. Opioids are a focus of CMS and of us, and then the interventions that we've done to manage that. I mean, just in terms of time here, our top sedative or benzo groups. So again, we're asked to monitor that by the age bands, which you can see. and then what percent of our fee-for-service patients are receiving those, and what are those drugs. It's interesting, it doesn't change in terms of the product mix there. Again, when you look at individuals with disabilities, we're asked to keep an eye on that. And so there's the numbers. With this therapeutic class, we have also done a number of interventions, one of which, again, a hard edit in our system. If we see a patient who's receiving a benzodiazepine and they're also prescribed a long-acting opioid, it's a hard edit. It won't process. We do have one for short-acting. At this point, we only ask for the pharmacist to intervene and provide DUR education on that issue. We've, as you know, we just launched a peer-to-peer on opioid and benzo combinations. So we're working through that. And I don't mean to rush. Please jump in if you got questions, but as you guys all know, we have very, very limited time. Here's ADHD stimulants. We're asked to look at this. A reminder, again, this is only fee-for-service. So obviously a lot of the women and children are with the ACOs. So we have a skewed population. 2.8% of those folks are receiving an ADHD stimulant. And there's the particular stimulants that are listed. Okay. Here it is for disabled individuals. 3.6 of them are receiving one of these meds. And then again, as you look at the interventions, we've implemented a number of different edits. One, some of these drugs are not indicated for very young children, and so those require prioritization depending on the drug, as you can see there. And then we just started. None of the guidelines recommend stimulants from 2 different classes. None of them recommend more than 2 stimulants. And we've put in place quantity limits. So we've done a bunch of things on the system side. And then we also did some very, very targeted outreach to providers that happen to have patients who were hitting some of these, for example, under 4 years old, receiving stimulants. Okay, so we did some interventions there. We went from, the number of kids on multiple under 4 from 7 down to 1. Okay. I'll let Dr. Larson cover this part.
So in July of 2020, or prior to July 2020, we had a number of documents to characterize our coverage. We had the preferred drug list, PDL, a list of over-the-counter drugs. We had our brand over generic list, our 3-month supply list, as well as we put our drug limits, quantity limits and such in our manual, and we had another list. I don't think we had a separate list of prior authorizations, just what was listed on the website. And so in July of last year, we combined all of these documents into a single cohesive document with consistent formatting and with the idea of making it more user-friendly to providers and anyone else who may need to use that reference. And that has been of value for us and for our providers. And we do keep that updated monthly. Joe, if you want to move to the next slide. Another thing that we've been doing is working on integrating medical or HCPCS bill drugs into the PDL so that we can have consistency in our coverage of drugs across both medical and point of sale. And that's not something that's been done all in one fell swoop, but it's something that we continually work on improving that integration as we come across drugs that may need to, that if there's an inconsistency, we fix that, or if there's a drug that comes to market that's medical and fits within a PDL class, we'll now include that on the PDL. And then we've also been more proactive with our management of HCPCS codes. Andrea and Sherry, a couple of our technicians, have done a great job in going through all of the HCPCS codes and making sure that we've got all the coding correct, the pricing. In the past, it was kind of a responsive type, you know, as things came up, we would respond and fix things as needed. And now we're proactive, and Andrea and Sherry keep these updated as updates happen, as there's new HCPCS codes, as there's new pricing files, and
let me just thanks, Brian, for that. So let me take questions if anybody has any, but to leave you with two different points here. This is a team effort. We're blessed with having fantastic pharmacy technicians that help us implement all of these programs, manage them, and make sure they're running correctly. Second, we've moved all of the PA function. It was formerly with nurses. Now it's all with the pharmacy department. Due to Jen's leadership, we've been able to do that. And as you see, with some significant improvements to customer service. So that would not have been possible without the team effort and Jen's leadership on this. So back to you, Noon, or questions, obviously.
Kumar,
Thank you.
You have a question?
Yeah. There's only one curiosity question. So children between the ages of 0 to 18 or something like that, there were 8,300 or something. And what about the disabled ones? Does that also include some children?
That's a good question, Kumar, and I don't know. Let me back up and say I'm sure CMS has defined where patients fall in those different groups. I don't have that right off the top of my head. I can get that for you if you'd like. But I agree with you that the individual with disabilities likely there may be some double counting, that they're both children and disabled.
Right, and the reason for asking question is because if you go at older citizens, right, who are included in the data, that number is like 10,000 something. So I'm wondering if this number is kind of, instead of 8,000, it could be 10,000, right?
It could very well be. But all of that is set by our friends in Washington, D.C., and we report as they tell us the report.
And what bothers me is I think we should be focusing on children first, because there may be some habitual type of thinking going on with the kids, and we ought to stop.
Thank you. We like to think that all our patients served by Medicaid are equally important, but certainly children deserve some focus. Thank you.
And could I just comment on the change in form this year for the Medicaid reports? The managed care forms have these tables that Joe went through are brand new to do Support Act requirements. And the managed care plans have the exact same tables with their data in them. They are submitted to Congress right now in a very large report. They are publicly available in November, at which point we had wanted to work with the ACOs and display some of that data to the board. So that is something we will be bringing in the future. We'll also bring our data analyst who built these tables for us, and we'll be able to dive a little bit deeper into the details of this year reporting.
No, excellent integration effort. Thank you.
Okay, we should transition to the presentation from the DRC.
Okay. Who do we have? Joanne?
Joanne, I think you're on mute.
Can you hear me now?
We can.
Great. All right. So I recognize that we're down to just the last few minutes of this meeting. The reason I'm here today is to just present the activities that we did in the prior year, just from October 2019 through December of 2020. The reason we included December of 2020 is because the interventions that we did included a look back period that extended just into prior to October. So it's for activities for patients who receive prescriptions in the reporting period. Just in the way of an overview, I'm just going to introduce kind of the rationale for the work that we're doing, and then I'm going to spend most of my time on the provider level normative feedback interventions and the educational interventions that we did last year, which were a new activity for us. And I think the DUR board reviews and the P&T committee reviews, you're all pretty familiar with the work that we do there, but I do have some slides dedicated to that if there's time. In the way of introduction, these are the three missions that we worked on last year. The second and third are the DUR board criteria sets and the P&T committee evidence synthesis reports. But the first one was to conduct the provider level interventions to address drug use criteria that are of interest to the Utah Medicaid drug program. And this was something that was new for us in the past. They were provider level interventions, but they addressed patient level considerations. And this year, we were focused more on provider level prescribing habits. The staff that have kind of worked on all of these activities are listed here. Many of them are people that you know. Just in the way of program rationale, we're all kind of aware of the increases in utilization and costs associated with prescription drug expenditures since the early 1990s. This slide just shows kind of a historical quarterly summary of numbers of Medicaid recipients who are utilizing prescription drugs. And so the blue line is all Medicaid recipients and the red line is the fee-for-service subset. And you can see here, where Medicare Part D was implemented, when the Accountable Care Act provisions first started to go into effect, when accountable care organizations are implemented, and at that point we started to have separation here in the way we're representing the data, where the fee-for-service subset are shown. This shows where most Accountable Care Act provisions have gone into effect, where ACOs are expanded to 9 more counties in Utah, and then this is where the current reporting period begins, and where the most recent eligibility expansion was fully implemented. And as you can see, that what we've seen here is that the numbers and the proportion of all Medicaid recipients that were fee-for-service has gone down in the current reporting period as new members have joined. And then this just shows kind of the same information, but in terms of just prescription drug prescriptions that were filled in the period. So trends that we saw were that proportions of patients in the fee-for-service subset out of all patients continued to decline, particularly in the first 4 months of the reporting period, which is a trend that we've observed in most years since 2013, and that the fee-for-service subset receives more claims per patient, and the expenditures are higher per patient, suggesting fee-for-service patients may have a higher medical need, and there's also been a decrease in absolute numbers of fee-for-service patients at the same time that there's been a large increase in enrolled patients overall. Our provider interventions, this is just a schematic that shows the activities that were involved in that. So basically what we did was we identified some intervention topics. Topics were selected to maximize 6 priorities that we had, including timeliness, which meant that we wanted to coincide with other planned initiatives that Utah Medicaid was conducting. And so you'll see some overlap between the topics that we were working on, along with some of the things that Joe and Brian were talking about as we were trying to kind of match the activities that were ongoing at the Department of Health. We also wanted our interventions to have an evidence basis. We wanted things to be particularly evidence-based, guideline concordant. So we looked for topics that had a good evidence basis. We also wanted our activities to have good construct validity, which meant that we were looking for things that were validated and or standardized, or even just well-established metrics for characterizing prescribing behavior. We also wanted things to have face validity, which meant that they would be intuitive to providers and clinically relevant. Our interventions, we wanted them to be simple, which meant that, you know, any given intervention would just focus on perhaps just one metric rather than many metrics. And then comparability, where we wanted to be able to look across metrics and be able to say, you know, a particular threshold for a metric on, you know, January's intervention could be compared to June's intervention. And even if it was a different disease state, it might say, you know, that the provider, the same score would say the provider was an outlier of the same sort of number of standard deviations, for example. And so what we did was we collaborated with the Department of Health to identify intervention topics. And then we developed the materials that included cover letters, a normative feedback report that described what the intervention was about, what's the disease state, what's the evidence basis, and then what does the score mean. Then we created provider report cards that reported the metrics in both terms of like raw values and standardized, and their value in terms of standard deviation units relative to the mean for a couple of comparison groups that I'll show you in a minute. And then we sent them out with surveys so that they could tell us, you know, what the, you know, how they felt about the interventions, or at least what they thought about the interventions. And then we also provided patient lists if they requested them. So we didn't send those out in the initial packages due to privacy considerations, but if providers requested them and gave us a secure mechanism to deliver them, we provided those. Then we calculated the metrics and sent out the normative feedback packages. I just kind of walked through all of this, but this is just to show the way we standardized, and we just used Z-scores to standardize metrics. We used Medicaid claims data and administrative data to operationalize metrics. We identified patients that met particular criteria, and then potentially eligible providers were identified from drug claims. So all of the providers who engaged in, you know, prescribing related to the particular activity, which I'll show you a list in a minute, would be those would be the denominator, and then those that were outliers would be the numerator, and those would be the ones that we sent the normative feedback packages to. And so this would be things like, you know, high dose opioids. If you have a large percentage of your patients receiving high dose opioids and you're an outlier in that regard relative to your peer groups, then you might receive a normative feedback intervention. We also did some educational interventions that did not include metrics, and these were just things that were better suited to broad-based educational initiatives, like notifying providers of changes in policies or educating providers about new guidelines and things like that. But the methods for identifying topics and developing materials were the same. This just shows a list of some of the topics. So you can see we did a lot with opioids and psychiatric drugs. We looked at amphetamine use in children and adults. So several of these metrics did relate to opioids or gabapentin use and chronic pain and things like that. So in terms of the numbers of normative feedback interventions, this right here, the denominator or the numerator shows the number of interventions that were sent out, and the denominator just shows the numbers of people for whom a score could be calculated with each metric. Here's an example of one. This was concurrent opioids with opioid use disorder treatments. So this was when patients were receiving overlapping therapies for opioid use disorder and opioids. We looked for those patients and sent normative feedback interventions to 63 providers that were, you know, in various degree and specialty subgroups that are listed here. This just shows some redacted, just the materials. This was a cover letter, and the cover letters were designed to be similar across all interventions. This was a normative feedback report, which summarized evidence and explained the metric. And then this would be the metric. So this provider, it would have been days, some of all prescribed days of overlapping opioid and opioid use disorder drugs in the look back period, which was usually about 3 months. And then this was their mean, the mean for all prescribers, for all other physicians, and then for all other family medicine prescribers. And this was a family medicine prescriber. And so, and then this was the Z-scores. And so, you know, this is the number of standard deviations away from the mean that this provider was with their particular score. And then we also illustrated their scores relative to their peers, the 3 different comparison groups. And so this is like a normal distribution. This would be, you know, the top 5% of outliers. And then this would be where the provider's score was. We also asked for feedback. So we just said, you know, there was a survey that they could say, you know, how useful they found the information. And they could also request a list of the patients that were identified in the month's report. And for some of the interventions, we were able to follow, you know, over time, kind of the change in the score. And so with this particular one, for example, we did see a decrease in the percentages of patients or providers who still, you know, in the score, in the raw score, as well as the percentage who still exceeded the threshold of the score that qualified them to be an outlier at baseline. We also did concomitant opioid and antipsychotic drugs, which was a little bit less compelling in terms of the changes over time. We saw an initial decrease and then an increase. We looked at high dose gabapentin use, and this was kind of the you know, following the changes over time in the high dose gabapentinoid prescriptions. And then we also did, these are just the 5 educational interventions that we did in the year. And so that's the end of that. And I know we're out of time, it's 8:31. But if there are any questions, I'm happy to answer any questions that you may have.
Thank you very much. That was great. Any questions? Okay, hearing none. I guess just a reminder, our next meeting, October 14th, and we will be discussing topical lidocaine for pain. Is there a motion to adjourn?
Move to adjourn.
Is there a second?
Kumar's got it.
Yes.
Thank you, Kumar. All in favor of adjourning, say aye or raise your hand.
Aye.
All right, we are adjourned. Thank you. Good to see everybody.